Welcome to 2 Minute Anesthesia in Critical Care. Let's discuss why ICU patients lose so much blood. Anemia is the most common hematological manifestation in critical care, defined as a hemoglobin less than 13 grams per deciliter in men and 12 grams per deciliter in women. Some reports suggest it affects 60 to 90% of critical care patients within 1 week of admission. It is associated with increased complications, length of stay, and mortality. During a critical care stay, patients can lose up to 40 mL of blood per day simply by diagnostic testing. This is clearly significant when the normal daily production of red cells in health is 0.25 mL per kilo. Red blood cells are produced, i.e., erythropoiesis occurs in the bone marrow under the control of EPO, erythropoietin. EPO is produced by the juxtaglomerular cells in the kidney in response to decreased oxygen delivery, i.e., anemia or hypoxia, or increased levels of androgens. The likely result of anemia in most critical care patients is multifactorial, relating to disease and iatrogenic factors. Iatrogenic factors include impaired enteral feeding, dilution with fluids, regular sampling, and interventions, for example, line placement, hemolysis within circuits, for example, CVVH, surgical interventions, and also pharmacological agents which increase the risk of bleeding, for example, tinzaparin. Now we can discuss the disease-relating factors. These can be split up into three different groups. Firstly, those which reduce RBC production. In critical illness is associated with myelosuppression, an abnormal erythropoietic response to anemia leading to a reduction in reticulocyte count, reduced iron availability, i.e., during critical illness, for example, sepsis, bacteria and the body compete for iron, and in order to combat this, the iron stores are sequestered, resulting in low hypothermia and also an iron deficient erythropoiesis, ultimately contributing to the anemia. In addition to acute kidney injuries, which reduce EPO, and also nutritional deficiencies, for example, iron, folate, and vitamin B12. Secondly, those which reduce RBC function due to abnormal RBC structure and reduced 2,3-DPG levels leading to reduced O2 delivery. And finally, loss of blood from bleeding, but also coagulation disorders from either platelet or liver dysfunction. The biochemical changes during critical illness are highlighted in the table. These also reflect the changes observed in anemia of chronic inflammatory disease. Note that ferritin increases, therefore it's a positive acute phase protein, whilst transferrin is a negative acute phase protein, and this decreases. Vitamin B12 and folate stay the same, and those biochemical changes which decrease relate to iron, so serum iron, total iron binding capacity, transferrin and transferrin saturation. Methods to reduce ICU-related blood loss can be conservative, medical, or surgical. Conservative measures include reducing blood loss by reduced sampling frequency, the use of microsamples, and point-of-care testing, in addition to individualized targets for hemoglobin. Medical management. This includes ongoing patient supplementation, management of coagulopathy, which may include clotting factors, temperature control, and calcium infusions, and finally, packed red blood cell prescriptions, which should be based on accurate hemoglobin values and patient factors, i.e., restrictive versus liberal transfusion targets. Restrictive targets usually are less than 7 grams per deciliter, whilst liberal targets are usually between 9 and 10 grams per deciliter. And finally, surgical management may be indicated.